All right, let's get into it. Today, we're basically playing detective, but our crime scene is one of the most complex parts of the human body, the jaw. We're going to break down the whole diagnostic challenge of cystic lesions and hopefully turn those confusing shadows you see on an X-ray into some clear-cut diagnoses. So, let's start our investigation.
You know, it really all starts with this one simple question. A clinician is looking at a totally routine X-ray and suddenly they spot it, a dark area, a radiolucency, right where there should be solid bone. So what is it? Is it harmless or is it something aggressive? This is the central mystery we're here to solve today.
So yeah, you can think of the maxillofacial region as our scene of the crime. And believe me, it is full of potential culprits. Our goal is to really get a handle on these cystic lesions, figure out how to identify them, how to classify them, and ultimately know exactly what we're up against.
Okay, so to solve any mystery, the first thing you have to do is organize your evidence and line up the suspects, right? That's exactly where we're going to start, with the master classification system.
Now, I know this chart looks a little intimidating, but the most interesting thing about it gives us our first and, honestly, our most crucial clue, the origin. If you look right at the top, you'll see all cystic lesions split into two main families. First, you've got odontogenic, which just means it's related to how teeth develop. And second, non-odontogenic, which means it comes from other tissues. Getting this first step right, well, it changes everything.
So here's the bottom line. Are we dealing with a problem that started from all that complex machinery that builds our teeth, or is the source something else entirely? Answering that one question immediately cuts our list of suspects right in half. Okay, so now that we've got our suspects organized, it's time to build a profile for the most wanted. Let's take a closer look at the key players from each category, their typical behaviors, and their telltale signs.
First up is a real heavy hitter, the odontogenic keratocyst, or OKC for short. This one is a major aggressor. It's famous for its super high recurrence rate. We're talking up to 60%, which means it absolutely loves to come back after you think you've gotten rid of it. And under the microscope, it has this signature look, a palisaded basal layer, where the cells are all lined up neatly side by side. We often call it a picket fence. That's its calling card.
But, and this is a huge but, not all keratin-producing cysts are created equal. This is so key for differential diagnosis. Here, we're comparing that aggressive OKC with its much calmer cousin, the orthokeratinized androgenic cyst, or OOC. The main difference? It comes down to the type of keratin and that basal layer. While the OKC has that very distinct picket fence, the OOC's is flat and pretty unremarkable. One is aggressive, the other is benign. That is a critical distinction to make.
Next up is one of the most common developmental cysts out there, the dentigerous cyst. Its identity is pretty straightforward. It is always found surrounding the crown of a tooth that hasn't erupted yet, usually a wisdom tooth or a canine. And as you can see in these diagrams, that location leads to three main patterns on an X-ray. Central, where it's perfectly centered. Lateral, where it's off to one side. Or circumferential, where it just envelops the entire tooth. Now this one, the calcifying odontogenic cyst, is also known as a Gorlin cyst. Its defining feature, its microscopic fingerprint really, is the presence of these really fascinating ghost cells. These are basically enlarged epithelial cells that stain pink, we call them eosinophilic, and they've lost their nuclei. When a pathologist sees these, the Gorlin cyst shoots to the top of their list.
Of course, not all cysts are developmental. Actually, the most common type of all are inflammatory. The apical periodontal cyst, sometimes called a radicular cyst, is the direct result of an infection from a dead or dying tooth. It's really just the body's attempt to wall off that infection right at the tip of the root. And yep, they have a microscopic clue too. These tiny arc-shaped things called Rushton bodies in their lining.
Okay, let's switch gears and talk about the non-tooth-related suspects. For these cysts, the number one clue is always location, location, location. They tend to form in very predictable spots where embryonic plates fused together way back when. The most famous one is the nasal palatine duct cyst. You find it right in the midline of the upper jaw, and it often shows up as this very distinctive heart-shaped shadow on an X-ray. Now, moving into the soft tissues, we've got another pair of lookalikes, dermoid and epidermal cysts. The difference here is all about what's on the inside. A dermoid cyst is congenital, meaning you're born with it, and it can have complex skin structures inside, like hair follicles or sweat glands. An epidermal cyst, on the other hand, is usually acquired from some kind of trauma, and it only contains keratin, that kind of foul-smelling cheese-like gunk. So what about salivary glands? Well, they have their own cysts, and they're usually born from one of two different stories. On one hand, you've got the mucocele. Think of this as a spill, where trauma, like biting your lip, ruptures the duct and saliva just pools in the tissue. It's not even a true cyst. On the other hand, a mucus retention cyst is a blockage, where a duct gets clogged up, swells, and creates a true epithelium-lined cyst. So, spill versus blockage, it's a really simple but elegant distinction. And finally, meet the imposter of the group, the aneurysmal bone cyst. Here's the thing. Despite its name, it's not a true cyst. Why? Because it has no epithelial lining. What it is a benign but really rapidly growing tumor-like lesion that's just filled with blood. It's known for causing this blown-out look on an X-ray, and you see it most often in patients under 20. It's the perfect example of why you can't always trust a name. So we've profiled the suspects. We've seen their signatures. Now it's time for the final act. How do clinicians actually take all these clues and put them together to crack the case? This slide, this is basically the detective's cheat sheet. Every keyword here is a powerful clue. You see a picket fence under the microscope? You got to think OKC. You find ghost cells? You should suspect a Gorlin cyst. See a heart-shaped shadow in the midline? It's almost certainly a nasopalatine duct cyst. These are the visual shortcuts that point you right to a specific diagnosis. But, and this is so important, the definitive diagnosis never comes from a single clue. The real solution lies in what we call the diagnostic triad. It's all about synthesizing three things: the clinical presentation, so what the patient says and what you can see, the radiographic evidence, the story the X-ray is telling you, and finally, the histopathology, the final verdict from the microscope. Only when all three of those pieces of evidence agree, that's when you have your answer.
So why does all of this detective work matter so much? Because the diagnosis dictates the treatment. It's that simple. If you misidentify an aggressive OKC as its benign cousin, the OOC, you risk undertreating a lesion that will almost certainly come back. Getting the identification right from the start means the right surgery, the right follow-up, and ultimately the best possible outcome for the patient.
And so we end right back where we started, with that shadow in the bone. But now we know it's not just a shadow, is it? It's a collection of clues, and the ability to read those clues correctly, to tell the difference between what's benign and what's aggressive, that is the absolutely crucial first step on the path to finding the right cure.